Yes, sir. Good afternoon to one and all present here, and welcome to your favorite channel in understanding cancer, Cancer Reach. Cancer Reach is an initiative by our very own oncology expert, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers access the right treatment at the right time. Today, we're going to be diving into a condition that is not so super common, but it is incredibly important to recognize it. It is called as superior vena cava syndrome. Now, if you've never heard of it before, don't worry. We're going to break it down in a simple and in an understandable way. But before we dive into the topic, I'm going to introduce Dr. Krishnamani to you. So he has completed his medical graduation in 2005, his post graduation in 2010, and his and specialized in medical oncology in 2014. Dr. Krishnamani has been actively involved in academic contributions and professional development. In addition to his clinical practice, he has a deep interest in research and has participated in multiple clinical trials. He has served on the advisory board for clinical research. His commitment to advancing the field of oncology is further demonstrated by his membership in American and European oncology societies. Currently, he is working at AOI hospitals in Hyderabad. A very warm welcome to you, sir.
Hello, thank you. Welcome to Cancer Reach. Thank you so much for joining us.
So, sir, can you tell us a little bit about today's topic? Like, what is the superior vena cava? Before we dive into what the syndrome is about.
So, why we chose this topic is this is a medical emergency, if we say, in cancer, one of the medical emergencies. So, if you look at this diagram which you have put up, you have the heart, you have the main aorta, which is the main blood vessel, which is in the red color, and then the venous blood or the bad blood is shown in the blue color vessels. So the vessels from the heart which go towards the neck, they are all part of the SVC, which is called the superior vena cava. So the superior vena cava is the main vessel, and to that drain many other smaller vessels like the brachiocephalic, innominate, subclavian, etc. So bottom line is the veins which drain from the heart to the head. This is the part of the SVC. If this gets blocked for whatever reason, it is called a SVC obstruction. Obstruction means blockage. What happens then is all the bad blood stays in your upper part of the body. So the blood is venous blood, it is bad blood. It means it has less oxygen. And then and why is it happening? Because of an obstruction in one of these upper veins. And as a consequence of that, you develop certain symptoms. And then you have to evaluate what cancer somebody has got and diagnose and treat. Only when you treat will that SVC syndrome improve and the patient gets better.
What are the main causative factors for this condition?
So we are talking on cancer. So cancer is the number one of the important factors. A very important factor is endovascular intervention. So what happens is nowadays people have stents placed in the veins. People have catheters placed in the vein. People have pacemakers. These are called cardiac conditions. So anything foreign in your body has a chance of getting blocked. Your body is natural. If you put a metal or a plastic or anything, basically a foreign object into your vein or artery, it gets blocked. So one of the most common causes we see today, because medical science has advanced so much, we do so many procedures today. So endovascular interventions, endovascular means inside the vessel. So you look at the superior vena cava here, right? So inside the vessel, when you do some intervention, if you put a stent or you put a pacemaker, if it gets blocked, they can get SVC syndrome. Many years back, when tuberculosis was rampant, TB, chronic TB was one of the causes of SVCU due to pericarditis or whatever. Now you don't see that much common. Cancers are a very important cause of superior vena cava syndrome. And today we'll be discussing and we'll be focusing more on cancer because other things are not part of our what do you say daily working system. So since we are cancer people who deal with cancer, we will be talking on cancers which lead to SVC syndrome. And if you ask anyone what are the common cancers which can cause SVC syndrome, lung cancer, in which small cell and non-small cell, then non-Hodgkin's lymphoma, then certain diseases called germ cell tumor, testicular tumor basically, or germ cell tumor. They form large masses in the mediastinum, that is near the heart area between the lungs, and that can compress. So anything which can compress the SVC. Lung cancer comes there, it compresses the SVC. Hodgkin's, NHL comes there, non-Hodgkin's, it compresses. Your germ cell tumor can compress. Hymoma. So these are all the common tumors which come in that area. They compress the SVC, they block the SVC. Because of the blockage of the SVC, the blood doesn't drain towards the heart. It stays put in the upper part of the body, and then you develop the complications and symptoms.
So, is it only of one type, or are there is there a classification system? Are there many types of SVC which are there?
So you can classify SVC. So in classical teaching, so when we were doing our MD days, this is one of my favorite, my teacher's favorite topic. Is it a pre-azygous block? Is it a post-azygous block? He used to ask us to examine the patient and say. So there is an azygous vein which drains into the SVC. So is the block before the azygous vein going into the SVC or beyond that? Number one. Number two, now there is a newer classification called type 1 to type 4, which is based on which vein is blocked. That is a very medical classification, anatomical classification. Another classification is whether there is an external compression or an internal block. Okay. Another classification is whether it is thrombotic or not. Thrombotic means is there a clot or it is not a clot. Another way you classify is this an acute or a chronic? Acute means SVC syndrome which has happened within 14 days. Subacute is 14 to 28 days. Chronic is more than 28 days. So, and whether you are symptomatic or asymptomatic. So for a common man like you and me, okay, somebody has SVC syndrome. Does he have symptoms or no? Is it thrombotic or no? How quickly has he come? Has he come within 14 days or after 1 month? Acute or chronic? Okay, so malignant versus non-malignant. Is it a cancer causing SVC, or you have some stent or some cardiac pacemaker, whatever, which is causing SVC? So this is basically you're trying to classify SVC, and also lastly, for the doctors or for the surgeons or for the cardiac endovascular people, pre-azygous, post-azygous, or type 1, 2, 3, 4, based on which vessel is blocked and which vessel is patent.
Is this condition more predominant in any one gender, or you can see it equally among men and women?
So when you talk about cancer causing SVC, what cancer? Now small cell lung cancer more common in smokers and men. So SVC of small cell is seen more in men. Germ cell more in men. Your NHL again almost with equal predilection you can see, or slightly more common in men. So the SVC doesn't have a SVC obstruction doesn't have a predilection. It is based on the cancer which you have on the background.
Okay. Is it same for the age groups also? Like pediatrics will
Same.
also be affected and adults will also be affected equally?
Yes, it all depends on the rapidity. Suppose you have a tumor sitting in your heart or around your heart for a very long time and you're not or taking cognizance of it, it will go slowly and block the SVC. Suppose it's a fast growing tumor, you don't have time. By the time you realize you already are in SVC. That's why you're calling an acute SVC. Now imagine a lymphoma sitting there, which will grow rapidly, which will double in 2 or 3 days. That will grow so rapidly that you will, by the time you develop symptoms, you already have SVC.
If a patient is experiencing symptoms, like what kind of symptoms would the patient experience which would direct you to think it is SVC syndrome?
One patient can be asymptomatic. You will examine the person. You may sometimes, so see, so you very beautifully put up all these images. See There are photographs labeled number one. So if you look at number one, this gentleman has a facial plethora, number one and number two. The face is red in color. It's like a cherry. That's called facial plethora. So what is happening is the blood is staying back in the head or in the upper part of the face. It's not getting drained. So these patients, when they are symptomatic, they can present with facial puffiness. The face can become swollen. They can present with redness or plethora. You look at the image in the middle where the veins can get uh, prominent. In fact, more than these veins, the veins on the chest wall get prominent. That is collateral veins. Collateral vein means body is trying to form new veins to bypass the obstruction. Got it? And finally, that photograph of the other guy who is having his hair, fist over his head, that basically signifies if STC syndrome becomes even more severe, blood circulation to brain decreases. So you develop giddiness, you develop excessive sleepiness. Sometimes you can develop fits or seizures. So symptoms can range from asymptomatic to mild tortuous chest wall veins or neck veins to facial plethora, redness, puffiness, swelling of the face, swelling of the tongue. Sometimes the swelling in the face can become so much in the swelling in the face and neck that it can compress your larynx. You may not have a voice to speak, or you may develop stridor. You may have breathing difficulty, or you may have difficulty swallowing food because it presses on the food pipe. So it presses on windpipe and foot pipe. If it becomes very severe, your neck is swollen, tongue is swollen, eyes are swollen, and finally you can go into unconsciousness or syncope or fits. So these are all a part of the spectrum of STC syndrome.
Okay. How would you diagnose that a patient is having SVC syndrome?
So you are going to diagnose clinically somebody with all the symptoms we discussed. Clinically examine, unbutton the person, look at chest wall veins, look at facial plethora, look at puffiness, ask for symptoms of excessive sleepiness, seizures, syncope, falls, etc. Okay, and then you will do scans or an X-ray or a CT scan. You will find something sitting in the mediastinum, that is between the place where the heart is, between the two lungs, and an MR or CT will finally help you. And if you think there is a tumor sitting there, then as we always discuss on Cancer Reach, tissue is the issue. So your test to, I will do a test to diagnose the tumor, which is a biopsy, which is a needle test. Then I will do tests to confirm the, to stage the disease, that is with a CT, MRI or a PET scan or whatever. Finally, you will do basic blood test to assess the fitness of a patient. So one is clinical exam, two is CT or MR, three is a biopsy, and that's the way you. So people also do something called a CT venography, where they put a dye through the vein, and that dye gets blocked at a particular point where there is the obstruction. So that is the final.
And supposing, like you just said, it can be asymptomatic also in some patients. So for asymptomatic patients, the clinical examination would not be a part of it.
No, clinical will be part, but you will not find much symptoms, or much signs rather. So the patient is asymptomatic. You may not find signs. You may find subtle signs in the form of maybe just the chest wall is dilated, veins are dilated.
Okay.
Subtle signs.
Okay. And moving on from diagnosis, after diagnosis, how would you base the treatment for the patient?
So the treatment is based on how bad the patient is. So somebody has come very sick. So first, what you should do, A, B, C, airway, breathing, circulation. Imagine somebody has come with their complete foot pipe and windpipe choked and they're unconscious. First, you have to save the patient. So you have to find an airway. You will do a tracheostomy. Okay. Breathing, you have to give oxygen to the patient. Circulation, you have to start some IV fluids. So always secure the life of a patient, airway, breathing, circulation. Treatment is based on the severity of symptoms. If somebody comes with very acute STC and you have a tumor which is not chemoresponsive, like maybe non-small cell, not super chemoresponsive, like a non-small cell lung cancer, then what you will do is you will go into the SVC and put a stent because you want immediate relief of symptoms. You have a chemo-responsive tumor like lymphoma, germ cell tumor, then what you will do is, see, my tumor will melt like ice to chemotherapy. Don't worry, let me give you chemo. Within 2 3 days, you will get better. There is no need of stenting. So you will see how quickly the patient comes, how bad the patient is, symptomatic or not, acute or chronic presentation, and what kind of cancer you have. So very sick patient in organ failure, airway breathing circulation is first, and then you'll put a stent. Non-chemo responsive cancer like non-small cell lung cancer, you'll put a stent. Chemo responsive like germ cell or lymphoma, you'll give steroids and chemo. If after this the patient is not improving, stent is always an emergency measure. Certain precautions which we take in the clinic, which we tell our nurses. Somebody comes with SVC syndrome, don't put a cannula in the hand, your vein access, IV line, because if you put a cannula in the hand, all the blood again, the IV fluids you give will go into the upper limb. And upper limb is anyway blocked, upper part of the body. So always cannulate the lower part. So put a cannula in the leg in SVC. We give diuretics so that they pass a lot of urine, so that the fluid comes down from the head. We give steroids. The head end of the bed is a bit elevated and they receive oxygen. So these are the basic measures. The specific measures we discussed: chemotherapy for chemo-responsive diseases, for radio-responsive diseases, radiotherapy, for immediate relief, stenting. And then if there is a thrombus inside also, you will go inside and either chemically, melt the thrombus called thrombolysis, or you will put a catheter and remove the thrombus called thrombectomy. But bottom line, your treatment is decided by how badly the patient comes, how symptomatic he is, how quickly he comes, how severe he is, and based on the underlying cancer.
So, sir, a few myths which you need to bust for SVC. Supposing a patient is having a stent and he has been diagnosed with lung cancer also, is it true that the patient will develop SVC syndrome?
No, there's no rule like that.
Okay. And so the other myth is that if the patient is having, would all patients of the cancers that you have specified, like for example, lung cancer or testicular cancer, would all the patients suffer from this because of any one risk factor?
No. The risk of developing STC in all of them must be less than 3 or 5%.
Okay, sir. So coming to the last part of it, what about the precautions that we can take or the doctor can take for not developing the syndrome?
Yeah. So basically, if you have a tumor in the mediastinum or any of these common tumors, you're not going to wait to start treatment for a very long period of time. For a patient also, it is true. Don't sit with a tumor. You have a tumor, get it treated. Number one. Number two, any of these symptoms you have, rush to the doctor. You need to seek medical attention. It is a medical emergency. And initial treatment may be stenting, but finally your treatment will be tumor directed, either chemo or radiotherapy.
Any parting words before we close the session for SVC syndrome, sir?
So the reason we chose this, and this is not a very commonly discussed topic amongst the common people. In medical fraternity, yes, we discuss it. And it is a medical oncological emergency. Patients should be aware that there is something like this existing. Otherwise, most of the time they will think it is some kind of a headache or a migraine or a fits or something. The underlying problem is due to your cancer. And it is also not due to spread of your cancer to brain. Your brain is fine. So please understand it's a medical emergency. It can occur in common cancers like lung cancer, lymphoma, germ cell tumors. You can be asymptomatic. But if you have any of these symptoms, we said, please rush, seek medical attention. If left untreated, it could lead to severe consequences. And treatment, if instituted timely, your results will be very good. Symptom relief will be very good.
Thank you for this wonderful session and thank you for educating us for a topic which is not commonly heard on the social media, superior vena cava syndrome. So, with this, I'd like to end the session here, sir. Thank you so much.
Thank you so much. Thank you. Bye.